right, guys, thanks for tuning in to the Best Practice Show podcast. My name is Kirk Behrendt. I'm your host, where we take a look at the best business practices from the best dental practices all over the country and all over the world. And boy, do I have a treat for you. I've got one of my favorite people, one of my heroes in dentistry. You'll see why in no time. Dr. Mark Murphy, and he's going to be talking about how DSM saved some practices during the pandemic, dental sleep medicine, because that is the algorithm that people are looking to unlock. And you're going to see this guy knows exactly what he's talking about. So do me a favor, grab a pen and hit the share button. You're going to absolutely love this. Now, before we get started, we got a lot of young dentists and dental students listening. If you're here for the first time, I just want to do two things. Number one, I want to welcome you to a community of no egos. We're just here to learn. You're going to find learning is kind of like our mantra around here. I'm just so happy you showed up. Number two, I want to encourage you to subscribe. So I don't care if you're listening on Spotify, iTunes, see that little button right there? Just click subscribe, because you'll see every single week I'm going to show up and bring you another expert in dentistry.
Aren't you glad you have a straight man like me? Click the button.
You'll see this is going to get more interesting with the minutes that go on here. And you'll see we'll just give you great information, create a better practice and a better life. And then lastly, we take a lot of show notes here. So everything Mark and I talk about in this great episode, which you're going to love, I'm going to have my writers write all this up. So everything about Mark, what he's going to mention, all that stuff, I'm going to make this the easiest learning. If you're listening on Spotify, just flip up, go to the notes, click the link. It'll be right below everything Mark mentioned. So make sure you check that out. Now, my guest today, I got to say this, I've told you this publicly. I enjoy every minute with you. You and I have been, you're one of my heroes in speaking. Now, I'm newer to the scene than you, and we've been around for a while. But when I first saw you speak, I'm like, this guy, I freaking laughed.
I'm getting my feet up off the ground there. It's getting really deep over here, man. It's getting so deep. I got to get my feet up.
I was sitting next to somebody and they're like, dude, don't you know Murph is he's like the Robin Williams of dentistry. I was falling out of my chair. And I don't know, I don't even remember the lecture you were doing, but then you went off on this riff. I laughed so hard. I missed half the lecture because it was so funny. And at the same token, as I got to know you in our trips down to the Panky Institute, you and I actually shared a room in the condos. You made me sleep on you're like, no, seniority here. You sleep on the couch type of thing. And then you got me involved in the backpack thing. So now I carry the same backpack you do. And you've just been a great friend of mine.
Kitchen sink,
baby. So it's awesome. And so most of you, if you're listening to education, you know who Dr. Mark Murphy is. You're going to be in for a treat. But Mark, if somebody's listening for the first time, who the heck is Mark Murphy? And give us a little bit of your story.
Wow. Mark Murphy is a deep thinker. He's a serious kind of guy. I got to say something though first. I know I'm not the only favorite person you ever have on your show, because I do listen to your podcast. They're incredible. Your CE's been incredible. You have helped thousands of practices weather this storm during the pandemic. I mean, the number of people that were listening to your podcasts, listening to your webinars, and learning from you, and just think about, you were able to put on the kind of courses you did, because you don't know 5 or 10 or 20, but you know 300 or 400 presenters in sleep. And we all came, not in sleep, but in clinical education and dentistry, we all came running. Yeah. When you asked for help, people were lining up to want to lecture and teach for you on these webinars, because you're just so fun to be around, exciting to be with, and you're so positive and enthusiastic. And it's just fun to teach with you and all the people that you work with. So it's great to have had a small part in that. Thanks for asking me. Thanks for having me. Thanks for having me back today. So it's great. Thank you.
My pleasure, man. I shared this with you before we went live. I had a full out panic attack, and I didn't know what to do. So I had all you guys on my phone. You were one of the first people I texted. I'm like, Murph, let's do something. You're like, game on, let's do it. And then, you know this, dentistry is a noble profession. I don't know how I fell into this, but it's a freaking noble profession with great people. You call anybody, they're like, I'll help you. And I feel blessed. And so I feel blessed to call you my friend. Now go back to this. I want to know your story just a little bit, because we're going to get into dental sleep medicine, but I always like people to know who they're listening to before you're an authority in a lot of things. And now
I've had a weird journey. Kirk, you and I have talked about this. So I'm going to bore you to death for about 3 or 4 minutes, which means 15. Because that's how I roll. I like listening to myself talk. I like looking in the mirror. I'm a handsome man.
There you go. Right.
If my wife could hear me right now, she'd be throwing stuff at me. So,
I do.
so I was really fortunate because back in 1999, I'm out doing some lecturing and teaching, and I'm teaching at Pankey, and we're all hanging out and doing the stuff that we all kind of like to do. And I'm picturing my life as evolving to, I'm going to teach down at Pankey once in a while. I'm going to lecture once a month. I'm going to practice 3 days a week, and I'm going to live happily ever after in the sunset in dentistry someday. And I got hooked up with a large laboratory group, a consolidator of laboratory groups, and they brought me on as a director of education, which is fine. That's great. I didn't know anything about that, but I knew something about it, I guess, but I not really in that role. So I did that, and then they were buying dental laboratories around North America, and so I noticed that they had one guy, and he was out of Calgary, Alberta, Darren Lemke, and he traveled all around the East and the West looking for dental laboratories. And I said, well, I could help you with that. Why don't you take West and I take the East? So I ended up working on mergers and acquisitions. I became a mergers and acquisitions expert, buying dental laboratories, evaluating them, valuing them, and then scrubbing the P&Ls, normalizing the P&Ls, and buying dental laboratories. And then working with that company, I ended up in a role as a vice president of operations. I've worked in marketing, sales departments. I was with the lab group. I left them to go spend a couple years at Pankey when Pankey was having some trouble back in 2005, 2006. Helped turn around Pankey, got that back on track. Left my board position to take the full-time role down at Pankey. Got that turned around. Now we've got Lee Brady down there. She's doing a great job. Fantastic. She's the goods. Absolutely there. And so we're back on track. So then I came back out of that and I didn't have a job. And it was kind of a panic attack like you were having there in March. I didn't have a job. It's 2000 and the end of 2006. I don't know where I'm going to make a dollar. I've sold my dental practice. I can go back and associate with him. He'd invite me in a second. And I decided, well, I'm going to go out and do some laboratory consulting. And so I did some consulting for dental laboratories. And honestly, I made more money that year than I'd ever made in my life. And so I did that for a few years. And then the folks at Mercer Advisors pulled me in. As you and I have had this conversation a million times, there's enough practices out there that need so much help that if you and I and 10 other people all started ACT Consultings, there'd be room for everybody. It's a total blue ocean. So I was with Mercer Advisors, and I ended up replacing a guy that some people have heard of, Imtiaz Manji, who, when they transitioned that company, he went away and ended up with Spear Education down the road, as we all know. They've done great. Good friends of mine, Gary DeWood out there, and Steve Radcliffe, Martin Mendelson, all those folks. So there I was working for Mercer and overseeing all of their dental consulting, doing the kinds of things that you do for people. And then you and I have had a chance to work together over the years. I've been fortunate enough. You've brought me in to do some lecturing, and I would call it rainmaking. I get some people interested in having some consulting and hand them off to you because it's not something I'm doing now. It's not something I want to do. I've dabbled in it for sure. I know a lot about it, but it is so labor intensive, Kirk. I don't know how you do it. You got an incredible team. You got incredible people. So yo to you for figuring it out. You've got systems in play. That's all about systems, even for you, isn't it? Not just the practices. You probably got your own playbook and all that stuff. I got to come see that. Yeah. So that's worked out. And then Prosomnis, which I'm with now as their clinical director, was an idea inside of Microdental Laboratories. So they brought me back in, Microdental did, after DTI and Microdental had merged. And they had me come in, and I was lecturing and teaching and doing education for them back in the days, and doing things for you and other people, and having a blast teaching at Pankey, back on track. Couldn't consult for other dental laboratories because I was helping consult for Microdental Laboratories. And then they developed a sleep device, which I knew a lot about because I made my first sleep appliance 30 years ago, teaching with Keith Thornton down at the Pankey Institute, teaching a TMD course. And in 2012, I was diagnosed with obstructive sleep apnea, so I was treating myself. And there you go. And so, and you have a great device, by the way. I've got a new one for you, by the way. We'll talk about it today if you want.
Thank you.
So anyhow, that grew from nothing to something. And when that company, when Microdental sold to Modern Dental, as those kinds of things happen, they did not sell the sleep device. They kept the sleep devices as a separate entity and rolled it out as a separate company. So a product inside of a large laboratory that lived as part of its removable department became its own company.
Wow.
And now they've gone from zero to, let's just say, an extra zero on the end of millions in sales in the United States, and the single most prescribed device in North America today.
Right. Now, I have so many questions, and I want you to talk about the why, because would you agree with this? And I'm sure you would. Airway's not going away. It was one of the most, and it was a hot topic before. Mm-hmm. What happened? Where was it before? what happened during the pandemic and like, where are we now with this conversation?
Yeah.
I think it's a huge opportunity, but like I said at the beginning, people don't know how to make money doing this. So
Yeah.
let's start with the big stuff first, the why. Why is this such an important conversation?
So there's a billion people worldwide, 1 billion with a B, that have obstructive sleep apnea. In the United States, it's estimated somewhere between 20 and 30%. We don't know for sure. 20 to 25, maybe as high as 30%. 45, 50, maybe 55 million, depends on which article. It doesn't matter. A shit ton of people have obstructive sleep apnea. Okay,
Right.
that's fine. Here's the bad part. 85 to 90% of those people have never been diagnosed or treated. So it's this huge pandemic within the country before we had the pandemic.
Right.
And it's not the fact that you snore. It's the fact that, of course, and the listeners know this, it's not just about the snoring. It's about the reduction in blood oxygen. Your SpO2 drops. So a reduction in flow, reduction in SpO2, you have what's called an apnea or a hypopnea. And if that happens too many times per hour, you're a sleep apneic. Well, you don't really die of sleep apnea. You die of heart attack, 23 times more likely to have a heart attack
Wow.
if you have obstructive sleep apnea than you don't. 4 times more likely to have a stroke. Okay? 10 times more likely to have an arrhythmia, depression, diabetes, congestive heart failure. We could go on.
Mm-hmm.
So, bad sleep, when we're supposed to be resting our body and recovering, resting our brain and recovering, bad sleep jacks with every part of our physiology.
Right.
So you look at that, it's this massive problem. And I'm going to tell you, once you dip your toe in treating that, just like any dentist who's dipped their toe in pain management, dipped their toe in cosmetic dentistry, dipped their toe in any aspect of dentistry that wasn't just drill, fill, and bill, it feels very rewarding. And now it feels very rewarding when you see the patient who maybe was snoring at night and their dog wouldn't sleep with them, and now they do. Or their spouse is back in bed with them from the snoring. Or they're able to decrease their medications. Or finally, their hypertensive medication works because they were drug-resistant hypertensives. And the number one cause for that is having obstructive sleep apnea. So any of those kinds of things, you see these health changes and these people's lives change, just like we did with cosmetic dentistry. And it feels great, right? And then on top of that, your team feels great. And then on top of that, you feel great. And holy crap, they pay very, very well for doing that. And
Right.
you don't bill it to these ever decreasing reimbursements from dental insurance. It's covered under medical. And so it becomes a very lucrative add-on to a dental practice.
Right. Well, let me increase the complexity in. Oh, this isn't.
I'll do it upside down. I'll do it upside down.
This isn't just a topic for the obese patient. It's not a topic for the old patient. Like now, and you know this probably better than us, kids now are going to the counselor office. They bring the parent in. The teacher says the kid can't focus. He's all over the place. They take him to a doctor. They write a script for speed, and the kid is on the speed for the rest 100%. Of his life when no one's asked a few questions, right?
Like, how does that kid sleep? Does the kid snore? Do they potty at night when they're not supposed to be? Do they get up 2 or 3 times? The Bears assessment, it's incredible. When we look at obstructive sleep apnea in kids, we see mostly sleep disturbances, behavioral problems, things like that. But think of how their physiology is getting whacked when they're 5, 6, 8, 12, 15, on their way to all the list of comorbidities that I talked to. How many people had abnormal childhoods because we didn't know about this?
Right.
That today we can go into that mouth and we can say, holy crap, you don't have enough room for your tongue, and it's falling back and it's helping choke off your airway. And so as a little kid snoring a little bit, and you think, well, it's not such a big deal. No, snoring is by itself an indicator that that child has obstructive sleep apnea.
Yeah, absolutely.
And so now you expand their palate, you expand their mandible, you grow it out. They quit snoring, behavior problems go away. They get off the speed, as you said. They quit wetting the bed at night, take the tonsils and adenoids out. There's all kinds of stuff like that. Just unbelievable. Now I do adult sleep apnea, but the folks that are doing pediatrics are incredible. Here's the challenge. Orthodontics, traditionally, it's changing now, but traditionally starts around, fill in the blank, 8, 10, 12, whatever the age might be. These cats are jumping into like my granddaughter's mouth. My granddaughter was treated at 5.
Right.
Her teeth were perfect, beautifully lined up. I use her in lectures. I use her pictures. Teeth are cute. She's adorable. You look at those teeth and you go, where are the big ones going to get? The big ones are going to come in. There's no room.
Right.
And so she's got a small bony box For a average sized tongue, breathing problems.
Now, I'm just going to keep adding complexity, and then you're going to make this simple. Your good friends like Gary and Steve that you mentioned from Spear Education, 35 years of treatment planning. It used to be 4 pillars of diagnosis. Now it's 5.
For sure.
Because Spear said this publicly, what if we make biology, aesthetics, function, all that stuff perfectly, but the patient still can't breathe? The world's best leaders in education know this is a pillar of diagnosis, correct?
In all of us, Pankey, Spear, Coyce, Dawson, LVI, everybody. Maybe LVI got there first, actually. I'll give them some kudos on that one. We were all running around fixing teeth, sticking in implants, doing incredible things to gums. Oh, man, this stuff's cool. Teeth are looking beautiful again, right? We weren't thinking very much about the airway.
Right.
So we were spending $10, $20, $30, $50, $60,000 on restorative solutions without thinking about the airway. So now Airwaycentric prosthodontics. That's a different way of thinking about it.
Yes.
Maybe drilling some holes in the maxilla and doing rapid palatal expansion on that, bringing the mandible down to forward. MMA, mandibular maxillary advancement, all those kinds of surgical procedures. Why? So maybe that person doesn't have to wear a CPAP or an oral appliance the rest of their life. Or certainly at least so that if I'm going to spend this kind of time, effort, energy, and money on their restorative care, that I do it in a way that's stable from an airway standpoint, not just stable from a dental, alveolar, bone standpoint. And that's something we didn't think about. So I made hundreds of splints on patients in centric relation. And that increased vertical dimension in centric relation would just rotate the mandible down a little bit. And back here, that closes the airway. I was closing the patient's airways who needed it open more than the other patients. I was killing my patients.
Wow.
By making them bite splints and being so attentive to MIP or centric relation.
This is being recorded.
Yeah, I know. And but it's what we knew at the time. It was the standard of care. You know, people that would use medications, procedures, etc., did the very best they could with the tools they had in their hands at the time. To do that today, to treat a patient who's a grinder with a traditional bite splint and not thinking about their airway, would open them up to potential litigation down the road.
Right. Okay. So now you're going to have to bring the world together here because we've got people at all different levels of dentistry. We've got, dentists that have been in 30 years, and I got kids coming out. I'm a 32-year-old dentist listening to you. Mark, break this down for me. Help me understand. I've been doing a lot of just like simple dentistry. Like, how important is this to my future? What would you want me to know about this?
So if we made a bucket in the middle that we said we're average dentists, whatever that means to anybody.
Hey, hold on one second. Your mic's scratching on something.
There you go. How's that? Better?
Yeah, much better. Okay, cool.
That was me scratching on my mic.
So go back to the bucket.
If we took a bucket and put people in it and we said, these are people doing whatever we might call average dentistry, whatever that means. And you said to me, Mark, these people are living lives of quiet desperation. They're frustrated. They're getting beat up by reimbursements that are declining every year. We know the statistics. You and I have shared those. The average dentist is working more hours, seeing more patients, doing more procedures, and he's making 20% or she's making 20% less money than they did 8 or 10 or 12 years ago. And if somebody took 20% of your money away tomorrow, you'd scream bloody murder. But if I took 2% away for 10 years, you might not notice, like the frog in lukewarm water brought up to a boil. So we've got that issue. And so these dentists are asking themselves, I'm making less and less money. We used to, the average dentist used to make $215, $220. Now it's $170. Where'd that $50,000 go? Well, it's gone to declining reimbursements, and they're working more hours, and it's feeling less fulfilled. And more patients are coming in saying, just do what's covered by insurance. Here is a psychological way out of that bucket. Now, it's also a economic way out of the bucket, and it's also a very emotionally rewarding way out of the bucket. But I mean, psychologically, I could go and provide a service to my patients who need it desperately, be compensated fairly for it, feel like $1 million when I treat them, watch them feel like $1 million when they get treated. My team will be enthused. So there's this incredible positive psychobabble kind of thing that goes on that's self-fulfilling in terms of treating that population of patients. Does that mean you just snap your fingers and it happens? Oh no, because now I have to live with 1 foot in medicine. I have to deal with medical insurance and billing. I have to deal with physicians in communication. There's a different type of documentation. There's a different sequence of events we have to do. But you know what, Kirk, you and I have seen so many dentists who we learned how to do dentistry, right?
Right.
We can learn how to do dental sleep medicine. It is mechanically incredibly easier than a bite splint.
Yeah.
Way easier than a bite splint.
Now go back to this, brother, because I know when you just said medical insurance reimbursements, dispel the rumor, because
half the people just signed off, right? Half the people
are like,
off.
I'm not going.
They pressed a different button.
They did. So go back to that. Dispel the rumor that's associated with that term.
So medical billing is a huge pain in the ass. It's a huge pain in the ass. And it would be a barrier for anybody, including me, if I had to figure it out.
Right.
If I had to figure it out, if I had any eyebrows left, and if I wasn't drunk all the time or up all night trying to figure it out, maybe I'd go back to doing dentistry. But the key is here, you don't have to reinvent the wheel. I'm pretty sure medicine has figured it out. And so all we have to do is let's do what they do. And guess what? They don't do it themselves either.
Right.
They pay a company, a third party, to do their billing.
Right.
And there's enough reimbursement in that model to pay your billing company. It's 8 or 10 or 12%, something like that. And there's still plenty left over that I assure you, in any model I've ever shown a dentist, it would still be their most lucrative per hour production, short of doing lumineers.
Right.
So, and they wouldn't feel good about doing the lumineers too often. I hope the lumineer people aren't listening. I don't mean to kick on you, but just that's not my ideal restoration right now. So those you can charge a lot for and just glue them on and right on top of the teeth. I'm making it funny. It's not fair. I shouldn't be picking on lumineers. Edit that shit out. Anyhow. But I am. So quietly. And I continue to, as I continue to move my lips and
But the truth is, if you learn how if you do exactly what you said, you learn how to write the story with the codes, whether you do it or somebody else. Medical insurance is required to pay, in some cases, full fee if it's affecting the patient's health. Now, I don't want to get into
No. I'm going to stop you there. Not full fee. Not full fee. Nowhere near full fee.
At least a significant portion.
A huge fee, but still not full fee. I bill about a little more than twice what my average reimbursement is.
Okay, good.
So if I bill $2 and I get 90 cents,
all right,
I would say, gosh, that's terrible, right? Well, if the 90 cents was the most money I was making per hour doing anything else in my practice, I'd be very excited about getting that.
Okay. Well, we'll do a whole separate one on medical because that's way outside the scope of my expertise. But I want to go back to the title, like how DSM saved some practice. So give me give me the condition before the pandemic. Pandemic hits. All of us were like scrambling. Like, is it teledentistry? Like, how do we get back on our feet? Walk us through how DSM saved some practices during the pandemic.
Yeah. So, March 12th, I was supposed to fly to LA to do a 2-day course on dental sleep medicine for DS3. And as things were whirling around as they were right there that first part of March, I decided not to go. And I made the right decision because they shut down California. I was lecturing in LA. That was in the middle of March. We already had at Prosomnis enough orders on the shelf called WIP, work in progress, that in the first quarter of 2020, we made all of our goals and objectives and forecasts and budgets and had a record quarter and everything like that. Very, very busy time. Dental sleep medicine grows 12 to 15% per year, no matter what. Okay. So it's a great big growth phenomenal. More dentists are getting into it. It's great for Prosomnis. It's great for dentists. Dentistry was thriving as well as it could at that time. The economy was good. The bottom fell out there in March, and dental practices shut down pretty much then and were closed for most of April and all of May. We lost 2 months. The average dental practice, according to the ADA today, is back up at around 75 to 80%. And they expect to stay that way for most of this coming year and not get back to 100%. Oh, there's exceptions. There's outliers everywhere. Right. So how did dental sleep medicine save some dental practices? Well, when your dental practice is closed and you're not permitted to do dentistry other than emergency work, what I do is not dentistry. It's medicine. I am a dentist, but I am a DME, durable medical equipment provider, for a very necessary disease that needs to be treated, obstructive sleep apnea.
Right.
And during the pandemic, it needed to be treated even more because if you recall in the beginning of the pandemic, some of these nursing homes and stuff with CPAPs running and blowing air all around the place were some of the worst places where transmission was occurring. They knew that they eventually figured out they had to isolate those people. And there was no more dispensing of CPAPs. There was no more testing in testing centers. And a person who has obstructive sleep apnea, just like a person who has a vitamin D deficiency, is 3 or 4 or 5 times more likely to die of COVID.
Wow.
So it couldn't go as an untreated disease. So there were a large number of dentists, and I worked with tons of them on how to stay open, how to see some patients part-time, still get your PPE loan, still get your IDA loan, do all the stuff you can all day long, but who could still see their sleep patients. Now, some of our practices were dentists who did some sleep. Some of our practices are sleep practices that do a little bit of dentistry, and some of them are 100% sleep. So they saw a reduction in their patient flow during the pandemic for sure, mostly because sleep physicians are usually pulmonologists, and they were in the hospital treating COVID patients and not doing sleep tests and sending patients to them.
Right.
So some of their flow was decreased, but the average sleep practice was still operating at 50 to 70% of its original capacity during the pandemic.
All right, give me a for example. So like some of it, one of your favorite docs. So like March, I'm figuring out what's going. April, I'm closed. May, what did give me? Were they calling patients, like going in the office? Like what did they do during that time?
We transitioned. Most of us trained and transitioned. I must have done 4 webinars a week during that time for dental sleep medicine audiences for different of our affiliate partners. We transitioned very quickly, and even Medicare, which is very important that Medicare allow this, because that's 20 to 25% of the average practice in dental sleep. They transitioned very quickly to a telemedicine model. So now I could do my initial consult, telemed. I could mail them a sleep test, teletest, let's call it that, home sleep testing, right? They could get a teleconsultation with a physician to review their sleep test. And I could get a prescription to treat them. And now they could come in the office, and the only time I have to see them is take impressions in a bite, 3 weeks later, deliver the device. And then I could teletitrate them from home. I'm going to tell you, I could teledeliver the device. I could mail it right to their friggin' house.
No.
And some docs did that during the heat of the pandemic. In May and April, there were probably 10 or 15% of the dentists who were not just doing telemedicine and teledentistry and telesleep, but they were doing teledeliveries. There were a few people who did teleimpressions.
Tell me more.
Telebite relationships.
Tell me more. Like, how are they doing that?
Where they mailed you a kit to take your own impressions and walked you through it over a Zoom meeting like this.
Okay.
Very, very few were doing that. It was something that we talked about, something we tested, different materials, different impression techniques. We immediately went into mode to support anybody who was doing that. And we would make comparisons between different ways that patients, and we tested with literally maybe a dozen patients with no impression experience. Could they take an impression that would be accurate enough for prosomnus? Because we have a pretty high requirement. Right. And we were challenged, but we worked with the Kettenbach people, and we were able to develop some syringes and some putty combinations that were able to do that. But then by the time we got all through that and everybody was doing all the tele and then, coming in all this garb to see their patients, you looked like a space person when you came in to deliver a device or take an impression. Then dentistry started to open back up again in June, and the sleep dentists opened up faster because they hadn't really completely closed. Most of them had stayed. There's a few that closed 100%. I can tell you, I can think of some names right now of people that completely shuttered their practices, people that misunderstood that when they said a dentist couldn't see their patients.
Right.
That didn't mean you couldn't see as a durable medical equipment provider, that you couldn't fit patients for that. Totally different. Now, you might not have wanted to because you might have been afraid of getting COVID. I get that. So I'd never say to somebody you should do that. But we were frontline healthcare workers helping stem the impact of the pandemic on our patient population when it came to treating dental sleep medicine, just like it was when we came to treating dental emergencies.
Right.
It fit into that kind of category.
Yeah. A disruption created an opportunity. I mean,
Yeah,
I
because
a lot of these people didn't change their protocols once they were back to work. They didn't go, okay, forget that. They continued to do that, or no?
no, I can tell you, I've done. I can count them on one hand the number of in-person follow-up visits I've done for patients that are like 6 year or 1 month or 6 month or 1 year follow-ups, and I can count on a couple of fingers the number of patients I've done my consults for or with that weren't like this in a Zoom meeting. We immediately, I only work, I work very part-time at this because I have a full-time role with prosthodontics in education and clinical director and stuff like that. So I spend a half to sometimes one full day a week doing dental sleep medicine. And I haven't done a consult on a new patient, maybe one or two since COVID hit.
All right. So we're going to talk about Jim Collins' 3 circles. Number one, the opportunity here is you're good at it. You understand it. You're changing people's lives. Well, number 2 would be you're good at it. Number 3 is how do we make money doing that? You know what I mean? Like you put all those 3 circles together, it becomes incredible opportunity. So give me the idea, like even in general terms, money's not the most important thing, but give me some perspective on the financial, like in a typical week, what did this look like?
So I would say to anybody when they're thinking about getting into sleep that you want to be emotionally invested in helping people get well.
Right.
And so you'll do that. But honestly, I mean, I would do what I do for free. I just wouldn't do as much of it. I would treat one patient a month and say, isn't this fun? But I'm not going to go spend 1 day a week at the office seeing patients unless somebody writes me a check. And I've got to pay rent to somebody because I don't have my own office anymore. I've got to pay my daughter who works for me, and I pay her very well. She wouldn't work for me if I didn't. I've got to pay laboratory fees for the manufacturer, medical device manufacturer fees. I want to pay myself when I'm done. I've got to pay the billing company their little piece of the pie. So yeah, I've got to generate some income. So it's, and I'll talk in really general kind of numbers because different states, just like in dentistry, have different fee schedules and like that. But it's very, very easy to see a patient. I'm on the phone with them 10, 15, 20 minutes consult, order up a sleep test. So I got 15 minutes invested, order up a sleep test, right? Good. Sleep test gets sent to their home. During that time, by the way, I assess that they're probably at high risk. If they're at high risk, that's good because now I'm about 90% sure that patient is going to come out the other end with a positive test for sleep apnea. And maybe 2/3 of those or more would get an oral appliance and 1/3 probably should still have a CPAP. Because there are some patients for whom oral appliance therapy isn't the right treatment. And it doesn't work for everybody. CPAP will work for everybody if they wear it, but most people don't wear it. Whole different class we could have on that too. But let's say that if I talk to 10 patients, 9 need a test. And if I send 9 for a test, 6 of them come back to me for an oral appliance. And I want to close 5 out of the 6. Okay. Yeah. Now we're talking the metrics that we'd have if I was thinking with my business hat on. And you and I've talked enough times, that business hat slips on really quickly. So now I have 10 consults, 15 minutes apiece, but I'm going to get 5 devices out the other end. 5 devices out the other end, it's say $2,500 a device. Okay. There's places where you might get 35. There's places where if you're doing Medicare, you might get 1,400. My blended average is close enough to $2,500 to use that number. It's a little bit below that, but just to make the math easy. So I'm going to do 5 devices out of those 10, 15-minute consults. When I do the device, so a consult, they go get a sleep test. Sleep test results come back to me. Another phone call to the patient to go over their sleep test results and advise them to come on in. We'll set up an appointment and schedule them for impressions, exam, and a bite relationship. Now, for me, the exam's a little bit more involved because none of them are my patients. I don't have a dental practice, so I'm not screening my own patients. That's one way to go. I get my patients, about 1/3 of them to 40% of them, from local sleep physicians. The other 2/3 from local dentists in the community who don't want to do sleep and trust me to do it for them. So they send me their patients. And they trust that the guy I rent space from won't steal their patients, or I'd have no job, no reputation. So now this patient comes in, I got to do an exam. I got to take upper lower impressions. I'm scanning. I take a bite. I can't spend an hour doing that. But let's say I block an hour. So I got 15 minutes up at the front. Now I got an hour. 3 weeks later, the patient comes back, 30-minute appointment. I deliver the device, deliver their AM aligner so they can get their bite back the next day. And 3 weeks later, I might have a 15-minute follow-up with them. The most I can invest in chair time is going to be 2 hours. $2,500. There isn't very many dentists practicing today. The ADA average is $350 an hour, a little bit more if you include hygiene, right? $750,000 practice, whatever the average numbers are today. So if the average dentist is billing out $350, heck, let's say the average dentist is billing out $400 an hour. I'll round it up for them.
Right.
And that 2 hours, they'd bill out $800, and I'm billing out $2,500.
Yeah. The bigger thing is you're changing people's lives. Obviously, like that gives me so
Well, yeah,
much perspective.
but you said, about the economic component, so I wanted to put that economic.
Well, they have to work together. That's where people get stuck. They're like,
otherwise, I do one a month. I'll do one a month and say, isn't this fun? That's like helping out at the soup kitchen. Do that once a month. Isn't this fun? Yeah. Do that 5 days a week. No, that's not happening.
Right. And would you agree with this? Like sometimes you just got to get started. Mark, I know you've done a lot of big cases. A couple of the first big cases you did, you lost every penny. Like you didn't make any money. Then you're like, I got to get a little smarter about this.
100%.
You don't get it perfect and then start. You just get started, right?
You could not have said any better. So I'm going to tell you about a conversation I had yesterday morning with a new dentist who's working with Prosomnus. And one of my jobs is to help coach these new dentists as they're getting going. And I had talked to her about 5 months ago, I guess, because it was August. 5 months ago, I talked to her in August. And I gave her all kinds of expertise and ideas. And I'm doing all my magic consulting in dental sleep medicine and helping her get started. All good. So she emails me and wants to know if we can talk again. Sure, we get on the phone and she's asking me some more questions about putting in systems in her office and how to do this and communicate with the doctor and stuff like that. So how's it going so far? She goes, well, it's a little slow starting. I go, well, how many devices have you done? How many do you think she told me?
0.
Correct. That's right. You knew it.
I know that.
Oh. And so here's what I said. I said, I will not answer another question that you ask me until you do some devices. I go, listen to me. I'll pretend her name was Kirk. I go, Kirk, you cannot learn how to swim by reading a book.
Right.
You have to get wet.
Right.
You need to go get wet. I said, did you ever prep a first crown prep in your life? She goes, well, yeah. I go, was it as good as the last crown prep you did? She goes, no. I go, you have to jump in the pool and learn how to swim. You have to put some of this theory. Now I'm going to tell you, I have that near exact conversation at least once a week with doctors getting started in sleep, reaching out to me. They heard a class. Some of these doctors have spent 3 weekends and taken all kinds of tests with the American Academy of Dental Sleep Medicine, and they are diplomates, board certified in how to treat dental sleep medicine. And some of them, the only case they've done, because they have to submit 2 cases to go through that program, are the 2 cases they did for the program, one on themselves and one on their husband or wife or brother.
Yeah. Who said this many years ago? Ready, fire, then aim. You know what I mean? Like that.
Ready. That was.
I have no idea, but all right.
It was not Stephen Covey. It was.
I don't know.
Oh my God! I can see it. Collins.
Maybe. I don't know.
Collins. Ready, fire, aim.
Just got to get started. So
ready, fire, aim. Fire again, aim. Fire again, re-aim. Just keep tweak it in.
Now, I know I only get you for a couple more minutes because you're a busy guy. I have a couple more questions I got to ask you. Okay. So like you've taken us through, the financials of this, the importance of this, now I'm getting my brain around, oh my gosh, this is just another component that really helps change people's lives. What can we anticipate? It's anyone's guess, but Mark, you're involved in a lot of key opinion leaders conversation. What's the future look like for DSM?
It's rosy. It's fantastic.
Why?
Think of the numbers I gave you earlier of the number of patients who have obstructive sleep apnea that are untreated.
Okay.
Also think of the fact that I forget exactly how old you are. You are not in my baby boomer group. Okay, so you're in the next generation, but in my baby boomer group, we're getting ready to retire, dude. And so the Medicare component is growing even larger. Okay, and some of the risk factors are being male, being old, being overweight. Our country, our society is getting fatter. In 1994, we did not have one state that was above 20% obesity rate. Today, in 2019, last year that I saw the data for, we did not have one state that was under 20% obesity rate. So we're we're getting older. Our mandibles are getting smaller. We're not using them to chew, eat mushy food. So the market's growing constantly. Okay. Oh, and let's do this. There's maybe 500 or 600 dentists, 500 or 600 out of 18,000, 180,000, 500 or 600 really doing a lot of sleep and sleep only and busy practices. And there's about 5,000 or 6,000, which sounds like a lot, 4%, 5% of dentistry that's doing any sleep. And most of them are doing 1 or 2 devices a quarter. So we're not even doing any of the sleep. Oh, this story gets even better. Why the future's so great. Medicine controls almost $5 billion with a B dollars worth of medical device equipment, almost all CPAPs. About 4 or 5% of that ends up being oral appliance therapy. So if we just got them to trust dentistry better, trust oral appliances better, show them the data, which we've done many times, Prosomnus has been one of the leaders in that, they would then shift. If they just shifted 10%, our market would triple. We don't have enough dentists to treat them. So the opportunity, this even gets better.
Wait,
in the average, one more, and you get a set of Ronco knives. One more. In the average dental practice, let's say they have 2,000 patients. Let's say 25% of their patients have obstructive sleep apnea. That's 500. Let's say 90%, 450 are undiagnosed. They have 450 patients. Let's say half of them, they could get them to an oral appliance. That's 225. If they did one a week, that's 4 years. And one a week at $2,500, I'm pretty sure that's about $125,000 in additional revenue for the practice, and chair time that's no longer lost and empty, and extremely fulfilling emotionally, behaviorally, spiritually, as well as economically. I would never let the economics drive what I do.
Yeah.
But it's easy to say that if I make enough money. But that's.
So now you guys that are listening can see why I enjoy every minute with this guy. He bends my brain. I laugh. I get to see the picture, and you're a good dude. I love you dearly.
Thank you. But to get there, that doctor has to hire a billing company,
right,
use a different software because it's soap notes,
right,
and they got to jump in the pool.
Yeah, they got to jump in the pool. So any last thoughts around DSM? What's going on in the world right now? We're still in the pandemic. Wrap this up for us in a little bow.
So if you're looking at your practice revenue statistics right now, and you're talking with your ACT dental consultant, and you're looking for that next 20, 30, 40, 50, $100,000 in revenue per year, adding sleep will suffice to hit those kinds of numbers. You will feel better about yourself, your practice, your team will love what you're doing. You'll start off when you jump in the pool, like I said, by treating yourself maybe first, some friends and family. Somebody's married to somebody in the practice that has sleep apnea. You can't go very far before you find somebody who at least hates their CPAP. Do it right. Work with physicians. Do it right. Always have a prescription from a physician. Do it right. Always have an up-to-date sleep test. Do everything right. Buy the book. Earn physicians' trust. But you will not find something more rewarding. If I could wave a magic wand, we'd go from 5,000 or 6,000 to 50,000 or 60,000 dentists doing sleep tomorrow, and we would start to eradicate this disease. It would be like the vaccine shot I got yesterday.
Dude.
That's what it would be like.
Brilliant. You know those Guinness commercials when somebody says something and the guy goes, brilliant, dude. That is brilliant. I agree, brother. Now, I know people are listening. They're going to want to learn more about Prosomnus. How in the heck do I get a hold of you? How do I find out more about this? How would I jump in the pool?
Yeah, so email me and I'll send them some information to get them started. It's M. Murphy. That's pretty easy. M. Murphy at Prosomnus, prosomnus.com, prosomnus.com. Send me an email. And, I'll answer some questions. And if you email me back 4 months later and you still haven't jumped in the pool, I'm going to make all kinds of fun of you.
There you go. There you go.
And I'll talk about you on a program like this.
Hey, that's okay. We can, I have so many ideas and I'm going to volunteer you for this. I'm just going to tell you, I would love to do a regular series on DSM, just the mechanics of it.
Happy to.
Questions. I would love to gather the hardest questions and then bring them to you. And let's do a free for all.
I would be happy to answer those hardest questions because I do that every day.
Love it. Love it, dude. I appreciate you so much. So thank you so much for being on. So wait, don't go away. While we say goodbye to everybody else, thank you guys for watching and listening to the Best Practices Show. If you enjoyed this like I did, just do us a favor, hit the share button, share this with your friends. Keep sending us for suggestions that you want to see from Mark. I'm going to have him back over and over again. We're going to ask him some tough questions and he can always deliver some great answers. And so until we see you next time, keep watching the Best Practices Show. You guys enjoy the rest of your day.